Okay, let's start the very last of this set of podcasts, which we're going to now go into the different immunodeficiencies, which will primarily be, not primarily, it will be primary immunodeficiency, which is called SCIDS in kiddos, and then of course HIV and AIDS. So when we start thinking about different kinds of immunodeficiencies, think about the different cells that we have and which one of these, if you're going to have to have an immunodeficiency, would you want, and which one of these would actually be the most severe. So take a moment and think about it. Do we want no B cells, no TC cells, your helper cells, both 1 and 2, or macrophages? If you think about that for a few minutes, I would venture to guess that most of you guys are kind of torn right now between the B cells and the T cells. But honestly, the worst one to not have would be your macrophages. So think about a little bit why that might be. If you remember what the macrophages do, they're actually the cell type that presents antigens to the rest of the immune system. So if you don't have the macrophages, you could not activate either the Th1s or the Th2s, which would not be able to then activate the entire immune system one way, shape, or form. And another thing that you got to remember is that macrophages are also important just in the process of phagocytosis, and they produce many of the inflammatory mediators and complement proteins. So a lack of those would be totally devastating to the body. If you think about having no B cells, you would still at least have your cell-mediated immunity, right? So those TC cells would be able to directly attack. You, of course, would not have any of your immunoglobulins, so that would be a problem, but it wouldn't be as devastating as no macrophages. If you didn't have your TC cells, that would stop the destruction of infected body cells, but you still would have the IgGs and the IgMs and all the different immunoglobulins, so you'd still have some sort of immunity. If we didn't have the Th1 cells, would essentially be the same thing as a lack of the cytotoxic T cells, because they're the ones who present to the TC cells. And the Th2 cells would essentially be the same thing as not having any B cells, because those are the helper cells that present to the humoral immunity. So essentially, B and C are essentially the same thing, and A and D are essentially the same thing. Okay, hopefully that makes sense and is a good review over what we talked about a little bit earlier with some of the pathophys stuff, or the A&P stuff, whichever way you want to think about it. Alright, so when we think about immunodeficiencies, obviously we can have that primary kind, which means it's genetic or it's congenital, it's inherited, you have it from birth, or you can have acquired, and of course acquired means it's happening later in life. It's definitely more common than your primary. There are other types of acquired immunodeficiencies, but obviously the one we're going to spend our time on is going to be the HIV/AIDS. When you think of primary immune deficiencies, we can have our B cell deficiencies, which would be an inability of the body to produce antibodies. We can also have our T cell deficiencies, and that would really mean that we had the inability or an impaired ability. We would still have some ability to orchestrate that whole immune response because we would be lacking those T helper cells. It also means that we wouldn't be able to protect against infections within the cells, because that's really where the T cell immunity comes into play, is that they're able to directly destroy the cells. And viruses and funguses, some of those types of little beastie bugs actually insert themselves into the cells, and that's what happens. Where your B cells really deal with a lot of the encapsulated organisms like bacteria, because the B cells are a big have a big responsibility with opsonation, which is what destroys those encapsulated cells. Okay, let's go a little bit more detail into the most severe type of primary immunodeficiency, and you'll hear me refer to it just as SCIDS, but it stands for severe combined immunodeficiency disease. Once upon a blue moon, this was absolutely a death sentence. We have actually gotten much, much, much better at managing and treating this, especially when we are aware that we have it going on. And since it is a congenital or genetic, we know that it can either be X-linked recessive or autosomal recessive. There are times it actually happens from just a genetic mutation as well. You've got to remember any of these genetic diseases that we talk about, there's always new onset that's just due to gene mutation. So it does not necessarily mean that there was anybody in the family that had it. If this goes untreated and unrecognized, the baby will die before they're 2 years of age. They will just have such overwhelming infections. But if we know about it, we're actually doing pretty good at therapies and treatments, especially if we know about it within the first month of life. The pathophys on this one, don't worry too much about the exact pathophys. Just know that they literally have no T cell to work and they have no B cells to work. So a lot of times the way that this is going to present itself initially is that we're going to have a thrush type infection. And then ultimately we're just going to have this routine or repetitive infections from unusual agents. Things that don't normally cause infections in kiddos will be causing this babe to have some infections. And then the other thing is just this overarching failure to thrive, because the body is spending so much energy trying to fight off these infections without the resources they need to fight them off. They have no energy left to continue to grow and become big and strong, healthy little babies. It is a little bit challenging to diagnose initially because remember, mom gives baby a surge of immunoglobulins right prior to birth. So it's not as devastating in those first 3 months as it can be. But I will say most of these kiddos end up being diagnosed by about the time that they are 2 months old. But if it goes totally undiagnosed, untreated, remember these kiddos will be dead before they are 2 because they just will not be able to fight the overwhelming infections that they have going on at that point in time. And I know that this is going to date myself a little bit, but the picture you see here is the boy who lived in the bubble. And those of you who are old enough to have been Seinfeld fans might remember an episode with the boy in the bubble. But that kiddo that lived in the bubble had skids. Again, we don't hear about that anymore now because we are doing so much better at treating these kids. We can do, if we know that we have a baby who has skids and we do a stem cell transplant within the first 28 days of life, they actually have a 95% survival rate. That's pretty huge for a disease process that once upon a blue moon was a death sentence for this kiddo. If we can get that stem cell transplant done within those first 28 days of that neonatal period, their survival rate is essentially the same as any other baby. If we don't do it within that first 28 days, it's still a fairly successful procedure in that the survival rate beyond that first 28 days is about 73%. Again, it doesn't sound wonderful, but compared to what it used to be, it's pretty impressive. We will also utilize IVIG, which is just giving the immunoglobulin intravenously. This used to be our only treatment till we really got good with the stem cell transplants. We'll use this still if we have to or if we're outside that neonatal time frame. But there's a lot of side effects that are associated with the repetitive use of IVIG, so we're really trying to stay away from that. If you would see any kind of questions about, from an NCLEX or HESI perspective, about the use of IVIG in these neonates, one of the things you need to keep in mind is that we need to have our emergency drugs and equipment ready, because it is not uncommon for these kids to have a hypersensitivity type reaction that's going to need intervention. Again, one of the things to keep in mind, and we'll talk about this also with our HIV/AIDS, is that these children do need to have routine immunizations. If they're getting the IVIG, there is a very specified time frame on when they can receive the immunizations prior to or after the IVIG immunizations. But just as a general rule, no, we give the vaccinations so that they don't get some of those things we know to exist in the environment to be deadly or cause tremendous illness within the kiddos. But we will monitor the use of live vaccinations, so start thinking now. We'll talk a little bit more about this in a couple of slides about what are those live vaccinations that we might be a little bit more hesitant to give to an individual who is severely immunocompromised. As far as your nursing management is going to go, the most basic thing is the most important thing. The number one thing we can be doing is hand washing. That's going to protect anybody who's got any kind of immunodeficiency, and I have seen a lot of NCLEX questions on that, and students are very hesitant to pick it because it seems so simple and so easy. But hand washing is probably the most important thing we can do with these kids. The other thing to keep in mind for anybody, not just a SCIDS kiddo, but anybody who's immunocompromised, is we will often do neutropenic precautions. And some of the things that are involved in neutropenic precautions besides the reverse isolation or, wearing the mask when they're out of the room and anybody else who's coming into the room to put a mask on, is that they cannot have any live plants, fresh flowers, and they honestly shouldn't have any fresh fruits and vegetables. And the reason behind that is that those things tend to have a lot of mold and bacteria and spores living on and in and around them. Another thing that I've seen NCLEX do a lot with these types of kiddos is ask questions about room placement. So anytime you have anybody who's immunocompromised, you're going to make sure that we are keeping them in a private room. But even from a nurse assignment, ideally universal precautions should protect any patient from any other patient, but you're not going to give a nurse a patient who's extremely contagious with a patient who's immunocompromised. Okay, so here's a question for you. Mr. Jones became infected with HIV virus on Friday night. The following Monday, he donated a unit of blood. The blood's going to be screened for the presence of HIV using an antibody test. Will his blood test positive or not? The answer on that one's no, right? How come? Think about seroconversion. How long does it typically take an individual with HIV to seroconvert, meaning that they were exposed to the virus, but their body will not test positive because we don't have the antibodies yet to test positive. Because when we're testing positive for these, we're looking for the antibodies to the virus. Typically, it takes 1 to 3 months to seroconvert, but it can actually take upwards of 6 months. Okay, so you got to always keep that in the back of our head when we are talking about that. And that's why we talked a little bit about this with pregnancy. That's why CDC is actually recommending that we test all moms in the first trimester and the third trimester for HIV because they might seroconvert during the pregnancy. Okay, so let's start off with the HIV itself. And I have discovered when I was reviewing my slides that I've got quite a lot of repetitiveness. So I will try and not spend a tremendous amount of time on each one, but we will go through the slides and I'll hopefully cover all the bases, but not 12 times like I think my slides have. When you're thinking about HIV, some of you might be worried about this just from an occupational hazard. I have to tell you that the HIV transmission among healthcare providers is extremely low. It is more common that we're going to end up with a Hep B from a needle stick than it is an HIV. Not that that's necessarily reassuring, but you don't necessarily need to be worried about HIV. Within HIV, there's actually two types. There's HIV-1 and there's HIV-2. Essentially, they are the same, except that HIV-2 has is much slower at transmission. But HIV-1 is a little bit quicker. HIV-1 is the one that we are most familiar with here in the United States. HIV-2 is found predominantly in Western Africa. But just know that there are actually two strains of the virus. We really just talk about them as the same thing, though, because they are essentially the same. You all are well aware that HIV is transmitted through body fluids, and this is all body fluids. Most common way of transmission is through sexual contact, but we also know that it can be perinatally, so we talked a little bit about that last semester from mom to baby. It is in breast milk, definitely blood to blood. Contaminated needles or blood transfusions, those are all ways in which we can transmit the HIV virus. When you are thinking about the course of an HIV infection, there is a couple of different stages, and we've been a little bit playing around with the terms that we utilize to describe these. But you've got your primary infection phase, your latent period, or some are calling that a chronic period, and then you've got overt or full-blown AIDS. So the primary infection phase is really, honestly, not anything that's highly noticeable. It's kind of just those signs and symptoms of any other systemic type infection. Fever, chills, headache, joint pain, vomiting maybe, diarrhea maybe, sore throat, occasionally a rash. There's really nothing that highlights that area or makes you think that there's really anything too significant going on. The time from infection to onset of symptoms, or essentially exposure to onset of symptoms, is typically a couple of weeks, 2 to 4 weeks, somewhere in that range. that primary infection phase can actually last about 2 to 8 weeks. So it's really just nebulous. I don't know if I can really stress that any more than it just is kind of benign in that aspect. After that, we'll go into that latent period. And that latent period is kind of a steady state. The virus is active during that steady state, but you as the individual, if you're the one who is infected, really honestly do not have any awareness that it's going on. Your immune system, being that it's starting out somewhat healthy, is able to actually kill the infected CD4 cells at a fairly decent rate. We're able to maintain functioning. Okay? So that latent period, really no clinical manifestations, maybe some lymphadenopathy, maybe. And this can last for years. I mean, years and years and years and years and years. And we're actually seeing this last longer and longer. In my notes, I actually have 10 to 11 years, but honestly, I think it's lasting even longer than that at this point in time. You will hear some clinicians refer to something called a set point during this clinically latent period, and that set point is just the level at which the viral load, or the titer, which is kind of the measure of the numbers of virus per the unit volume of blood, stabilizes. So you've got a viral load present, but it's not so high that it's actually causing you to be ill with it. It's just kind of going on, and there's really nothing much happening at that point. Some people will split out that latent phase into just clinically latent and then chronic phase. Some people will put those together. If they're actually separating it out to a chronic phase, again, it's just a couple of years, 2 to 4 years, what my notes say. It could actually maybe be even a little bit longer, where there are chronic symptoms and rising viral titers, but nothing's life-threatening. So essentially the individual during that point might be getting more sick with the disease, but they haven't gone into full-blown AIDS. To get to overt or full-blown AIDS, there's a couple of criteria that the CDC has identified. Essentially, as a general rule of thumb, from a testing perspective, if you think of full-blown AIDS as being a CD4 count, or TH, because remember that's what CD4 cells are, count less than 200, with an AIDS-defining illness, that's typically what it's going to count. So CDC's definition says HIV infection with an associated indicator of the disease, which include the CD4 count less than 200, certain opportunistic infections which we know to be related to AIDS, certain cancers that we know to be related, like Kaposi sarcoma, non-Hodgkin's lymphoma, invasive cervical or anal carcinomas. Those are cancers that are definitely associated with full-blown AIDS. Having the presence of wasting syndrome, which we will talk a lot more about, or having certain associated neurological diseases, or recurrent pneumonias, pulmonary TB. Those are aspects. If you've got the CD4 count with one of those associated illnesses or associated indicators, we will say you're at full-blown AIDS. The other way is just to, let me take a step back. Having one of the associated illnesses with a known HIV infection, they will say goes to full-blown AIDS, or having a known HIV infection with a CD4 count less than 200. And again, what I see most commonly asked or tested on within this is the CD4 count. So keep that in the back of your head, that you want that CD4 count less than 200 to be considered full-blown AIDS. And I got up here listed some of the AIDS-associated illnesses. We've talked a little bit about these, the opportunistic infections. This is like your pneumocystic pneumonias, or your GI tract infections with diarrhea or gastroenteritis. There are certain nervous system infections that are also associated with this, a dementia, blindness, paralysis, things along those lines. The malignancies that I've already talked about, and the wasting syndrome that I've mentioned before. And somewhere in my notes we will talk a little bit more about wasting syndrome, because wasting syndrome is something from a nursing management that we need to have constantly in the back of our head on how we're going to manage and or handle. And again, this is where I say I've got a little bit of repetition here. This just goes through that primary infection, clinically latent and chronic phase, to full-blown AIDS. So I'm not going to repeat this again, because I think I've talked all about this on the prior slide. There's really nothing new or different here that I needed to actually put in. And then here I kind of went into the pathophys just in case you're curious about this. I'm not sure that you would ever truly be asked specific questions about how HIV essentially integrates itself into the CD4 cells. But since we're talking about it, I went ahead and pulled up my patho slides of this. And from a big picture, the patho of this is that the HIV virus, the virus infects the CD4 cells. Essentially, the virus is going to take over the machinery within the cell to be able to replicate itself. And that's going to render the CD4 cell useless, or at least from the purpose that it's really intended for. And again, as we've talked about, that primary infection is followed by a clinical latency period during which time you might appear asymptomatic, but that virus is working overdrive within your system if it's going unchecked and we don't know that we have the HIV. And that's going to make the virus able to then ultimately cripple the immune system once it has enough of its little fighter cells working for it. But there are actually 8 steps in which this HIV infects a cell. And if you see up there, I've got a couple of questions up there of which of your body cells have CD4 proteins and CD4 receptors, because those are the things that are going to be affected by this HIV virus. And when you think about this, the T helper cells have that CD4 proteins actually on their surface, and that's what you can see there. That little round circle in step 1 is the HIV virus, and it's attaching to the CD4 protein receptor. They use these proteins to talk, so to speak, to other T helper cells and antigen-presenting cells by attaching to those proteins. But here the HIV virus is actually going to attach to it instead. Other T helper cells and antigen-presenting cells actually have receptors for it. I think I might have already said that. So essentially, the HIV is mimicking a T helper cell to infect cells that would normally interact with it. Does that make sense? So the HIV virus is taking over those protein receptors so that anything that would normally bind to those CD4 cells are going to be able to be infected. The next step is just internalization of the virus, which allows for that virus to essentially be uncoded, and so that it can start to do its work within the CD4 cell. The third step is just the DNA synthesis, and it's occurring because of reverse transcriptase. So I've got a question up there for you of what does reverse transcriptase do? And ultimately what it does is it takes that virus's RNA genome, so the genetic makeup of the RNA, and it makes a DNA copy of it. So it's really the chemical that's responsible for making the RNA of the HIV virus usable by the cells, because it needs to be in the DNA format. The thing to keep in mind is that this process actually has a very high error rate, which you would think was a good thing because maybe it would be faulty and not work, but it's actually a bad thing because it means we cannot make a vaccination for it because it's constantly changing. So it's actually one of the reasons why it is able to be as successful as it is. So the last 5 steps of this process is the 4th step, which is just integration, and it's done by a chemical called integrase. And that's where that new DNA enters the nucleus now, so the center of the T helper cells. And with the help of that enzyme integrase that I was just mentioning, it's actually able to insert its DNA into all of the cells then at that point. Then the 5th step is transcription of the DNA into messenger RNA. So now it carries a message on how to build the new viruses. And this involves activation of the T cells and induction of the host cells. So really this step is fairly important at this point. The 6th step that you've got up there on your pictures is really the translation of the messenger RNA. It's going to provide instructions for use on how to build the chain of proteins and enzymes that contain the components needed for the next stage. Okay, so that's what's happening in that translation. 7 is cleavage, and you can see we're almost back outside of the cell on that 7th step. And this is utilizing an enzyme called protease, and that's really just going to cut those protein changes down into individual proteins that can make up the new virus. And then that 8th step is just the final step where you're assembled into a new HIV virus and released from the T helper cells. At this point, they typically call them virons. and those virons will actually invade other T helper cells. And the thing that's really amazing to me is that our immune system, at least initially, is able to kill millions of infected T helper cells every day. The problem is the HIV cells are releasing billions. Okay? I mean, we're talking this big of numbers if that's not just totally awe-inspiring in some aspects. But that's ultimately that pathway of what's happening and how that virus is replicating within itself, or within the cell. Alright, some of this is going to again be repetitive, but I just wanted to kind of differentiate this to see, to make sure that we had a clearly defined line of the difference between HIV as well as full-blown AIDS. Diagnosis for either is typically done with an ELISA, a Western blot, or a PCR test. The ELISA actually is an acronym that stands for Enzyme-Linked Immunoabsorbent Assay. It's just a screening, and it's really just looking for the detection of antibodies. So it's either positive or it's negative. The Western blot, again, a little bit more. It's going to confirm the HIV, so it's not just a screening, it's actually a confirmation, because it has the ability to detect both HIV antibodies and individual viral components that cause reactive bands. Again, it's a positive or a negative, though. There's really no numerical values that go along with this. The PCR is a polymerase, sorry, getting tongue-tied on that word, chain reaction. And that's used to detect proviral DNA by identifying specific gene sequences. I don't hear us talking as much about the PCR as I do the Western blot. It might just be my pediatric involvement, though, with the disease more than anything else. When we are talking babies, it is really hard for us to truly diagnose an infant. We will actually test the infant every 3 months, but you've got to remember that if mom is HIV positive, she has transmitted those IgGs through the placenta, and so baby is going to test positive. So we actually have a couple of guidelines, but typically we don't make a definitive diagnosis until the kiddo is at least 18 months old, and at that point we'll do another ELISA and a Western blot. But if they have 2 tests that come back positive in a row, we do continue to treat as if they are HIV positive. Again, clinical manifestations we've already discussed. Those are just those flu-like manifestations, fatigue, fever, those types of things, because we're not going to be really out and out sick at this point in time. When we know we have an HIV positive individual, there is some nursing management for that we need to keep in mind. Obviously, vaccinations we will do. As long as the CD4 counts are above 200, they can receive all vaccinations. And if it's an adult, we'll actually make sure that they're getting the pneumococcal, the meningococcal, and flu vaccines. If it's a child, we'll keep them on their normal schedule. And we will only hold those vaccinations that are live attenuated vaccinations if they have active disease going on and their CD4 count is less than 200. So think about which those vaccinations would be that are live attenuated vaccinations. We will not potentially administer MMR and varicella. And the good thing for me, at least when I'm teaching this from a PEDS perspective, is that those vaccinations are given at the same time frame. So those are your 12 to 15 month, and again at the 4 to 6 years of age. So those will be held if the CD4 counts are low. But remember, we talked about wasting syndrome. And wasting syndrome is just the syndrome that happens in all individuals who've got full-blown AIDS, where the individual has unexplained weight loss of more than 10% of their ideal body weight. And it's associated with the cycle of malnutrition and subsequent wasting. But there's actually some nursing interventions, or some interventions in general, that can be used to potentially prevent this or at least slow it. So we'll make sure that we have aggressive nutritional support at the time of diagnosis so that we hopefully prevent or at least deter these effects. Some of the stuff that we know now, we know that zinc deficiencies is associated with the altered taste that these individuals have. So we've started utilizing zinc supplements. I know it may sound silly, but there's actually some research to show that utilizing plastic utensils instead of metal ones sometimes will help with that unpleasant tastes. And we know that there are certain foods that are better tolerated with this altered taste sensations. So we'll really push some dairy products, some fish, and some poultry, because a lot of times those are better sources of protein than red meat in individuals who've got this. Then obviously we're going to educate on the prevention of the disease and management of the disease. And then we're going to start them even in this HIV phase, typically with some of the medications, an antiretroviral therapy, a nucleoside analog reverse transcriptase that's going to inhibit some of the process within that patho. There's also protease inhibitors that we can utilize. Prophylactic medications for HIV is constantly changing. It might, if you're interested, play around on CDC website. You'll see some of the guidelines for the current recommendations at this point in time. We also know that with that wasting syndrome, we can give some appetite stimulants. They're oral progesterones that'll help hopefully prevent the onset or the occurrence of that wasting syndrome. So there's a variety of medications that we can utilize. We just don't. It's just constantly changing. Is really what I guess I want you guys to know, because they do get a certain level of tolerance to the meds, as well as this is just such a hotly researched area that we're learning more and more and more about. Okay, I have a feeling I'm exceeding my 20 minutes, but we're on the last slide here with our acquired immunodeficiency syndrome pictures. We've talked a lot about all of the aspects within this. I'm not sure that there's a whole heck of a lot different. We know that for us to be full-blown AIDS, at this point we have a CD4 count less than 200 with one of the other disease processes that are associated with AIDS going on. From a nursing management perspective, AZT and Retrovir, those are some of our antivirals that we can give that are very commonly utilized. We know that we can give immunoglobulins if necessary. Again, the same with the vaccinations. It's still important to continue to vaccinate. And then obviously at this point from a nursing management, as much as we can, we're going to be doing all the same old things that we would. Hand washing is an important thing. Avoiding contact with infected peoples and things like that. I'm not sure if there's anything else that I haven't said. If there is questions, of course, just ask me in class. And this will wrap up the rest of the immune system.